Hello, my name is Dr. Brian Burns, and I'm a specialist with the Greater Sydney Area Helicopter Emergency Medical Service. Today, I'm going to talk to you about transportation issues in pre-hospital and retrieval medicine. In this talk, I will compare and contrast road, rotary, and fixed-wing retrieval platforms. I will describe the legal considerations governing emergency response modes, and I will discuss aviation regulations and how they govern aeromedical operations. Core to both pre-hospital and retrieval medicine transport is the movement of a patient or patients from point A to point B. However, there are a lot of factors, both clinical and non-clinical, that need to be considered and addressed before and during transport. This talk will focus on the non-clinical technical aspects. So let's look at those transport platforms across the following headings: logistics, power and oxygen supply, loading and unloading, and patient access. Road transport represents the commonest modality of transport for critically ill or injured patients. Road vehicles employed by retrieval services such as ours are usually standard road ambulances that have several modifications specific to the retrieval environment and demands. An example of this is retrofit of an intra-aortic balloon pump loading device. In some jurisdictions, faster, smaller, all-wheel drive or four-wheel drives are used as rapid response vehicles to convey an advanced trauma team rapidly to a pre-hospital scene. However, these RRVs are unable to transport patients and require availability of a standard ambulance at the scene. Retrieval stretchers may be narrower compared to standard ambulance stretchers. In-hospital bariatric patients usually have to have anthropometric measurements done, particularly with respect to girth, prior to transport in a standard retrieval ambulance. At the foot end of the retrieval stretcher is the bridge. This contains a monitor, ventilator, and syringe drivers. This setup is essentially the same across all transport modalities. Currently, the retrieval ambulances in our service are being fitted with Stryker XPS stretchers. These stretchers weigh 4 kilos and with a hydraulic power loader are capable of loading a patient of up to 300 kilograms into the ambulance. However, as previously mentioned, girth may preclude transport by this platform. Road ambulances are kitted with standard road ambulance radios. These are called digital GRN or government radio network that allow communication with the Aeromedical Operations Centre, other operations centre, ambulances, and indeed other agencies. They're also kitted out with sat-nav and geolocation capability. Road vehicles are prone, like normal road vehicles, to traffic volume and rush hour. So depending on the clinical needs of the patient or tasking urgency, it may be appropriate to use lights and sirens response to get through traffic. This will be discussed in detail later. Power supply for the retrieval bridge comes from 12V DC power drained from the vehicle battery. Power is inverted to 240 volts AC via a switch on the retrieval bridge once the bridge has been plugged in and the engine is running. This power supply is indefinite while the vehicle is running. Individual devices on the bridge, such as the ventilator, monitor, and syringe drivers, have specific battery power supply time. It is important for the retrieval practitioner to be aware of those times. 240-volt power is also available through standard 3-pin sockets. Oxygen supply can be accessed from within the ambulance. Road vehicles carry 2 D cylinders, Each D cylinder contains 1,600 litres, and 2 portable CD cylinders which contain 460 litres each. These are easily accessible and are placed from outside the vehicle. So unlike a fixed wing or rotary wing vehicle, oxygen cylinders can be swapped out en route by stopping at a hospital or by liaising with another ambulance. Loading of patients is only possible via the rear doors of the ambulance. On loading, the patient's left side is snug to the left of the vehicle. This poses the potential for patient injury, line disconnection and ventilator hose snagging, and rarely disconnection or extubation. Vigilance is required. Once loaded, accessing the patient's left side, and particularly the left upper limb and left chest, is very difficult. This can have clinical repercussions if not recognized prior to loading. Unloading is the exact reverse process and requires the same vigilance. Road ambulances usually have 2 seats in the rear, one at the head facing aft and one at the left facing forward. Hence, there is good patient access to the right and the head, but not as good access to the patient's left as previously mentioned. Let's take the example of the patient with an unsuspected left pneumothorax, who suddenly develops a tension pneumothorax and requires urgent finger thoracostomy to decompress the chest. This is extremely difficult on the left side once loaded in a road vehicle. Fixed wing transport is the preferred modality for international or long distance retrievals. Typical civilian modalities include a turboprop engine or jet turbine engine. Within Australia, a turboprop, such as the Beechcraft King Air, is the preferred modality. Fixed wing aircraft usually operate out of commercial airports and may not necessarily have medical retrieval staff at the base at all times. In New South Wales, flight nurses staff the aircraft on base, whilst medical staff respond promptly from home or another road or helicopter base to perform medical retrievals with the flight nurse. Fixed-wing platforms have a very long range that varies according to fuel load, holding or alternate landing requirements, payloads, and crew numbers. Fixed-wing transports will usually land at a local or regional airport that allows an ILS or instrument landing system approach. In more remote or rural settings, fixed wings can land on an airstrip provided visibility and surface adequate and the runway is long enough. The Beechcraft King Air 350i has a range of around 1,500 nautical miles. Pilots must have a type rating to fly a specific aircraft type and must observe minimum runway requirements that assure a margin of safety if an engine fails during takeoff. Each aircraft will have a recommended runway takeoff length. The required runway length for the King Air 350 is the distance needed given weight, air temperature, wind, sea level, to accelerate to a decision speed, have an engine fail, and stop on the remaining runway. Or it is the distance needed to lose an engine after reaching decision speed and continue to take off to an altitude of 35 feet above the runway. Or lastly, the distance needed to take off and climb to 35 feet above the runway with both engines running increased by 15%. In Australia, CASA recommends, for other than agricultural operations by day, a runway length equal to or greater than that specified in the aeroplane's flight manual or approved performance charts or certificate of airworthiness for the prevailing conditions is required. Fixed-wing transports will nearly always require a road transport component to transport the retrieval team to the patient and for the return leg to the airport or runway. For stable, non-medical or flight nurse-only retrieval cases, flight team are often met at the airport by an ambulance transporting the patient. For medical retrieval patients, this is not practical or best practice for a number of reasons. Firstly, the patient is usually critically ill and local expertise may not have capacity to stabilize the patient safely for transport. Secondly, the staff from the hospital are likely to be out of their comfort zone or level of training in transporting a patient outside the hospital who's critically ill. Thirdly, providing critical care or resuscitation in an ambulance on initial assessment at the airport is fraught with difficulty. Lastly, practitioners leaving the hospital may denude the local facility and compromise other patient care. Fixed-wing aircraft are often the preferred option of aerial retrieval in bad weather such as poor light, poor visibility or high wind, or where there are holding requirements due to higher endurance fuel load, higher altitude cruise and superior ability to return to land at the original airport. However, there are some weather conditions where fixed-wing flights are also not feasible. Medical equipment and bridge power supply is through an AC inverter providing 240 volts to the bridge and standard wall-mounted electrical sockets. As in the rotary and road wing platform, the bridge devices have individual battery power. Electronic equipment for aeromedical work must be EMI tested according to CASA regulation for both rotary and fixed-wing aircraft. Furthermore, scheduled on-board equipment must be secured and rated to 20G crash rating. Defibrillation may be performed in flight, but should be done with prior permission from the captain of the aircraft. Medical oxygen supply is via universal wall-mounted outlets supplied by 2 D cylinders. There is also one portable CD cylinder in the aircraft. A separate emergency supply for sudden decompression of the aircraft of 2 D cylinders is also fitted to supply 100% oxygen to the pilot and co-pilot seats on demand and 4 litres per minute from the ceiling for medical attendants and patients. Loading of patients into fixed wings is by 2 main mechanisms, a sled or a hoist. Most aeromedical services prefer the hoist mechanism for occupational health, patient safety and flexibility perspective. New South Wales Ambulance Service King Air 350i operates a hydraulic hoist or stretcher interface fixture arm attachment, as you see here. This allows loading of bariatric patients safely and efficiently. The maximum patient weight by this mechanism is 260 kilos. Loading is through a side cabin door and the patient is positioned facing in a north-south orientation. This mechanism also allows intra-aortic balloon pump and ECMO transport. The Beechcraft King Air 350i can accommodate 2 ventilated patients on stretchers, a 2-member medical team and 1 seated passenger. As in the road ambulance, there is limited access to one of the patient's side depending on which side of the aircraft the patient is loaded. However, access to the head end of the patient is generally superior to a road or rotary wing platform. Rotary wing aircraft is the primary modality used in pre-hospital advanced trauma care in many developed countries. This is staffed by either a doctor-paramedic model or doctor-nurse model, or indeed dual paramedic or paramedic-nurse model. Flight crew consists of a pilot plus or minus a co-pilot, an air crewman, and in some instances, a rescue crewman. Helicopters allow rapid patient access and delivery directly to a hospital without concern for traffic. Sydney HEMS operates an EC145 and a Aw139, as you see here in the picture. The Aw139 is considered by many to be the gold standard helicopter for EMS operations. It has good endurance of up to 250 nautical miles, it's got good power, it's big, and it's fast. It has a V&E of 167 knots. and it's also able to land at most hospital helipads without exceeding the 6,400 kilogram weight restriction. Helicopters are expensive to run and require a lot of scheduled and sometimes unscheduled maintenance. Staffing is also expensive, and flight currencies need to be maintained by both pilots and crew. Pilots are either VFR or IFR trained. In most Australian HEMS, pilots are usually IFR trained and increasingly NVG capable. In some areas, HEMS also perform a search and rescue operation and are an excellent platform to access patients in remote or geographically challenging locations. They may access patients by landing at the scene or nearby landing zone, or by winch access to the patient, as occurs at Riga Air Ambulance and with us here in Sydney. Helicopters are not infallible and are prone to weather conditions and poor visibility. They have a maximum altitude range that precludes safe transit over mountains or exposes the aircraft to freezing levels, which can cause ice buildup on the rotors unless a de-icer is fitted. Rotary wing is subject to air traffic control, as are fixed wings in controlled airspace, and they also cruise and operate at a lower altitude and may operate winch missions. Therefore, there's an inherently higher risk. However, as you can see, these helicopters, or this mode of transport, is excellent at getting into very tight locations close to the scene of an accident. Operating outside the helicopter that is turning and burning is potentially dangerous from the tail rotor or by touching or grabbing the heated pitot tube. Situational awareness must be maintained at all times. Helicopters may be based in commercial airports, on hospital helipads, or privately run heliports or helicopter bases. Staff are usually positioned with the helicopter at the base on rostered shifts to allow for rapid response times to primary tasking or urgent intra-hospital transfers. The machine is usually towed out or moved out of the hangar on a sled if stationed inside. Helicopter operations involve a huge degree of communication in every phase of the mission, more so than any other platform, and have the largest degree of ambient noise and vibration. This can add to the cognitive overload that sometimes is experienced in operating in this environment. This is highlighted in a case such as this, which was a long-range bariatric transfer of a patient on extracorporeal membrane oxygenation. Helicopters are equipped with multiple communication devices both internally within the helicopter and externally, including the government digital radio or government radio network and satellite phone. In flight, the retrieval bridge is powered by an AC converter in the helicopter. However, once shut down, the helicopter battery will not power the inside lights of the cabin for very long and have enough power to restart the engines unless an aviation external battery source is available. This is not feasible on all primary missions. So this does have implications for the resuscitation and treatment of patients on the ground in the back of a helicopter. Oxygen supplied, like in other platforms, is in one cylinder in the EC145 and 2 D cylinders in the Aw139. Both platforms also carry a CD portable oxygen cylinder. All modalities are mounted with the same universal oxygen outlets as you see here. As alluded to, loading of a helicopter is potentially dangerous if done whilst the blades are turning. This is particularly with respect to the tail rotor or loading on the high side of a cambered or steep landing zone. If a hot load is done, entry to the helicopter is done at the 3 or 9 o'clock position after the OK signal is given from the captain. In the EC145, loading can be via the cabin door or rear clamshell door. Hot load is never recommended via the clamshell door. In the Aw139, loading is via the cabin doors. The Aw139 has the advantage in that the patient can be loaded east-west or in a north-south configuration. The latter can also transport 2 ventilated patients on stretchers. Patient access in a helicopter is dependent on the helicopter type, but considered generally difficult in all types due to G-force, crew and patient restraints, patient packaging, and patient position. Access in the Aw139 in the east-west position limits access to the airway. North-south allows better 360-degree access, but does involve some clinician movement to access all areas. At all times, the crew should be attached to the aircraft, hence movement on a wander lead is required if the patient is coming off seatbelt. Once packaged, a patient can be very difficult to further assess or to intervene on. Now let's look at the legal considerations of emergency response mode. In Australia, there is legal provision for the use of emergency response modes for vehicles. In New South Wales, the Road Traffic Regulation 2007, or Road Transport Regulation 2007, allows certain nominated vehicles act in an emergency response mode. Blue or red flashing lights can be fitted to the ambulances solely used by New South Wales Ambulance Service or a vehicle under its delegated authority. This is under the Health Services Act 1997. Lights must be roof mounted and visible in normal daylight from a distance of 200 metres to a driver approaching from any direction. Additional lights may be fitted to meet this requirement. Sirens may also be fitted and may emit a continuous wailing sound, an alternating hee-haw sound, or an urgent repeated whooping sound. Drivers of other vehicles must give way to vehicles in emergency response mode. Ambulance services have developed operating procedures for the emergency driving of personnel and use of warning devices. New South Wales Ambulance Service endorses compliance under the Road Traffic Act 1909 and the Australian Road Rules 2008 whilst emergency driving. Exemptions in certain circumstances can be claimed. And these are: they were taking reasonable care and it was reasonable that the rules should not apply, and if the vehicle is a motor vehicle that is moving, the vehicle is displaying a blue or red flashing light or sounding an alarm. The Australian road rules refer to the driver of any emergency vehicle where it is expedient and safe to do so. That driver may drive in any direction on part of a public street or overtake or pass on either side of another vehicle, but only with due care, may stop, leave, standing or park the emergency vehicle at any time or place, and may exceed the speeds prescribed by the Traffic Act 1909, number 5, only when safe to do so. In the operating procedure, the ambulance service states that the occupants of the vehicle must comply with the requirements of the Traffic Act, must drive at a speed and manner appropriate to traffic, road and prevailing weather conditions, must drive in a professional manner at all times, and must not proceed through a railway or tram crossing when the warning signals are in operation, unless directed to do so by an authorised person, and must wear a seatbelt at all times. Seatbelts must be worn at all times in the rear patient compartment unless immediate life-saving intervention is required, and this includes CPR. The driver must not enter an intersection or junction that is controlled by a traffic sign, light, or other road marking at a speed where the driver cannot stop the vehicle in order to avoid a crash or cause a crash. On approach to a traffic light controlled intersection faced with a red light, the driver must slow down and stop if necessary until all traffic has completely stopped. Once the traffic is stopped or safe to do so, enter and proceed through the intersection with caution. And school zone safety is highlighted. Furthermore, all emergency response vehicles require the use of flashing lights and sirens during Category 1 response. This is the highest category of response for the ambulance service. Blue or red flashing lights shall be activated at the commencement of all emergency drives, and the lights should remain active when parked at the emergency scene, unless parked in a position that affords maximum safety without the need to display the lights. Where the highest clinical level paramedic responsible for the patient decides that the patient condition warrants the use of emergency driving procedure during transfer, then lights and sirens can be activated. This decision must be communicated to the control center. A crew decision to upgrade the response to lights and sirens to expedite to a location for priority 2 incidents is allowable once communicated. And a siren should be considered on approach to any hazard. Helicopter and fixed-wing aircraft are afforded priority in departure and air traffic control by declaring a medical priority. CASA defines this as a flight providing transport of medical patients, personnel, and or equipment prioritized as follows. Med 1. Med 1 is an aircraft proceeding to pick up, carry a severely ill patient or one for whom life support measures are being provided. And Med 2 is an aircraft proceeding to pick up medical personnel and or equipment urgently required for the transport of a Med 1 patient or returning urgently required medical personnel and or equipment at the termination of a Med 1 flight. CASA is responsible under the Civil Aviation Act 1988, along with other functions, for developing and promulgating appropriate, clear, and concise aviation safety standards. In the performance of this function and exercises of its power, CASA must, where appropriate, consult with government, commercial, industrial, consumer, and other relevant bodies and organisations. Currently, air ambulance functions within the aerial work provision of Part 138 of the CASR, or Civil Aviation Safety Regulation. Medical transport operations are defined as flight in an aircraft, the specific purpose of which is to facilitate emergency medical assistance in situations where, to render that assistance, rapid aerial transportation is essential, or alternatively to facilitate medical assistance and transport where aerial transport is considered necessary as determined by a medical practitioner or tasking agency. This is by carrying ill or injured persons or other persons directly involved with the injured person or medical personnel or combinations of the above. CASA currently is in the process of regulating ambulance function flights to the same standard that are currently applied to aerial transport operations. CASA also notes that patients are often in no position to make informed decisions about the transport services they receive and hence seeks a more formalised process of safety. Among the leading aviation nations, Australia is unique in classifying medical transport flights as aerial work under the prescribed purpose of ambulance functions. This classification subjects Australia's medical transport operations to a different standard regulation than would be the case under the International Civil Aviation Organization aerial transport standards and those of most other leading member states. Under the proposed new regulation and alignment, a medical transport operator will be expected to have in place the following CASA-approved system and processes. Safety management systems, human factors and non-technical skills training, a method of managing personal fatigue, training and checking for personnel, and operator expositions, maintenance processes which include minimum equipment lists. Nearly all aeromedical providers in Australia already self-regulate in these areas. CASA does recognise that due to the specialised nature of some medical transport operations are often conducted outside normal aerial transport operations, involving the use of specialised extraction methods such as winching, confined areas for arrival or departure, non-standard runways, and night vision goggles. However, CASA seeks to implement these changes this year in close collaboration with medical transport providers. I'd like to thank you for taking the time to listen to my talk. Goodbye.